Hi everybody, welcome back to my channel Lively Life Snippets. I like a wise statement from Soren Kierkegaard which goes like this: life can only be understood backwards, but it must be lived forwards. Today, let's rewind to my experience last year in the Valentine month regarding my case presentation to understand highly active antiretroviral HAART initiation. The content was derived from one of the patient I had interviewed with my preceptor during my 1-week retroviral disease medication therapy adherence clinic RVD MTAC attachment. Please note that any content of this video does not substitute professional medical advices. If you have any health issues, please speak to your doctor and healthcare team. This video is a sample of few presentations that I had done during my Provisionally Registered Pharmacist PRP training in Malaysia.
The first-line treatment for antiretroviral therapy is using a combination of 2 nucleoside or nucleotide reverse transcriptase inhibitors and 1 non-nucleoside reverse transcriptase inhibitors. Examples of 2-NRTI are tenofovir and emtricitabine for 10M, lamivudine and zidovudine for combivir. Mechanism of action of NRTI is shown in top right-hand corner as the brown square stopper. It works by binding to the DNA chain produced by viral reverse transcriptase to terminates it. Subsequently, multiplication of virus stops. On the other hand, common example of NNRTI is efavirenz and nevirapine. NNRTI are shown in green circular stopper in the bottom right-hand corner. NNRTI works by binding to the viral reverse transcriptase and denatures it. Consequently, denatured enzyme cannot produce viral DNA chain and the multiplication process comes to a stop. According to the Malaysian Consensus Guideline on Antiretroviral Therapy Edition 2017, we need to take into account patients' comorbids and organ dysfunctions as well as the impact of the regimen on patients when deciding which agents to start. This is important because once started on antiretroviral therapy, it usually lasts throughout the patient's lives. Comorbidities such as renal insufficiency, hepatitis B co-infection, anemia, psychiatric conditions, tuberculosis and opportunistic infections need to be investigated because different drugs have different side effects profiles. In terms of impact of regimen, as a pharmacist, we need to support patients to be compliant to their treatment as much as possible to avoid resistance and treatment failure. Concerns regarding pill burden, pill size, potential for drug interactions, anticipated side effects, food or fasting requirements need to be addressed appropriately. For examples, for Muslims who fast during Ramadan, OD dosing will be much convenient compared to BD dosing, and it is not recommended to switch agents temporarily during Ramadan once patients have stabilized on a regimen.
During my RVD MTAC attachment, I interviewed Ms. KV on the 18th of February 2019. She is a young 25 years old Bidayu female who works as a cashier in a supermarket. She claimed to have no known drug allergies. She had visited doctor on the 21st of December 2018. She complained of vaginal discharge for 2 months. It had been yellowish with no foul smells, but turned brownish one day before on the 20th of December 2018. She claimed to had regular menses 5 days every month and her last menstrual period was on the 12th of August 2018. Her last sexual intercourse was on the 17th of December 2018 and was painful but no post-coital bleed. She had no abdominal pain, mass, vaginal bleed, intermenstrual bleed or oral thrush. She was not married and stay alone in rented property near workplace. She denied high-risk behavior and had a total of 3 sexual partners who were unsure of promiscuity or high-risk behavior status. Her second partner died in 201X of unknown cause. Her third or current partner is from anonymized place to protect patients' confidentiality. They had been in the relationship for 2 years. She had a 4-year-old child with previous partner as biological father. Her child was being taken care by grandparents in anonymized place. She claimed to have no known medical illnesses. She was not prescribed any medications or self-purchase any medications from retail pharmacies. She took Jamu capsule of unknown brand 1 capsule twice daily for the past 2 years.
Her blood pressure, pulse rate, temperature and fasting blood glucose are within normal range. She weighed over 90 kilograms. She was tested reactive twice for HIV antigen, positive for anti-HIV antibody and cytomegalovirus immunoglobulin G. Baseline full blood count results and renal profile are mostly within normal range except the sodium level slightly higher in 2018 and then normalized in 2019. Baseline liver function test and lipid studies are within normal ranges too. CD4 count is quite low at 330 cells per microliter and this implies high viral load. Pap smear results showed no known pathogens isolated.
She was diagnosed with gonorrhea on 21/12/2018 and retroviral disease 21/1/2019.
In the past, she was prescribed azithromycin tablets and intramuscular ceftriaxone for her gonorrhea. Last week on 8/2/2019, she was prescribed intramuscular medroxyprogesterone acetate 150 mg every 3 months for contraception, and her dose was scheduled to be on 2/5/19. She had underwent pill training using multivitamin and vitamin C tablets for a month from 21/1/2019 to 18/2/2019. Upon assessment, she was deemed ready to start antiretroviral therapy with 10 mg, which contains 300 mg tenofovir and 200 mg entrocitabine and efavirenz 600 mg on the date of visit on 18/2/2019, at the dose of 1 tablet once a day each.
Before patient was deemed ready to start antiretroviral drugs, pill training was necessary to establish a new habit of taking tablets daily to ensure compliance. We came to a consensus with patient to took the tablets at 11 p.m. before sleep as this is the most convenient timing for the patient. After 4 weeks, patient returned with 2 tablets of multivitamin and vitamin C. The pill count was correct and patient did not miss any doses, not even delay in timing. The compliance aids used by this patient included an alarm clock, phone alarm and pill box. Adherence score can be calculated by the number of pills taken divided by number of pills to be taken multiplied by 100. Our patient scored a 100%. Adherence score of 95% is linked to 78% viral suppression rate while a drop in 15% in adherence score is associated with a drastic drop in viral suppression rate, it falls by 4-fold. Therefore, it is crucial to maintain patients on at least 95% adherence score to yield benefits such as to sustain HIV virologic suppression, to minimize viral mutations, to reduce transmission and to keep therapy options available for the longest time possible.
There are 5 pharmaceutical care issues identified. The first one is there any interactions between contraceptives and antiretroviral drugs? According to Micromedex, concurrent use of medroxyprogesterone acetate and efavirenz may result in loss of contraceptive efficacy due to decreased progestin, including oral contraceptives, implants and injections. This is a moderate interaction with delayed onset. Since it is not an absolute contraindication, we suggest to use reliable barrier method. If efavirenz need to be discontinued, continue barrier method for 12 weeks. Consequently, patient has lower chances of unintended pregnancies. This paper proposed that contraceptive effectiveness of depot-medroxyprogesterone is not affected by antiretrovirals, and patients should be counseled on the expected rate of unplanned pregnancy. Although studies show depot-medroxyprogesterone is not impacted by efavirenz use, studies of women using efavirenz and contraceptive implants reported pregnancy rates ranging from 5 to 15 per 100 woman years, and combined oral contraceptives users taking efavirenz had pregnancy rates ranging from 13 to 15 per 100 woman years.
The second issue is IRIS. What is IRIS? It is an abbreviation from Immune Reconstitution Inflammatory Syndrome. It means pre-existing infections in individuals with IRIS may have been previously diagnosed and treated, or they may be subclinical and being unmasked by the host's regained capacity to mount an inflammatory response after HAART initiation. In other words, patient may experience a period of time where the symptoms worsen before he or she feels better. This is good sign because it shows the CD4 count is recovering and now being able to fight back the pre-existing pathogens which the CD4 cannot fight before this. IRIS often presents within the first 4 to 8 weeks after initiation or a change in antiretroviral therapy as mild to moderate disease or symptoms. Life-threatening cases are rare. Our concern here is patient may experience IRIS and stop HAART herself. To prevent this from happening, we counsel patient what IRIS is and emphasize to patient that it is just a transition period before getting better. We reassure patient HAART is working even though when there is an infection. Hopefully, this will reduce risks of intentional non-adherence due to misconception.
The third issue is Isoniazid prophylaxis therapy, IPT. Malaysian Consensus Guidelines on Antiretroviral Therapy 2017 recommends that Isoniazid prophylaxis therapy for 6 months should be offered to all HIV patients once active tuberculosis has been ruled out. Isoniazid prophylaxis therapy can reduce overall TB risk by 33%. Our patient was screened negative for tuberculosis, no symptoms, chest X-ray normal and did not have active tuberculosis. Patient was not prescribed Isoniazid prophylaxis therapy and newly initiated HAART today. We suggest to start Isoniazid tablets at a dose of 10 mg per kilogram with maximum dose 300 mg once a day and pyridoxine tablets 20 mg once a day at a later date, instead of today to lower pill burden and the risk of patients experiencing additive side effects from HAART and IPT.
The fourth issue is the newly started Tenofovir with renal tubular toxicity as the potential major side effect. To prevent this from happening, we suggest to monitor renal function at week 4, 8 and 12 upon initiation of Tenofovir. Monitor every 4 to 6 monthly if stable. Suggest to take adequate intake of non-caffeinated fluids, ideally 2 to 3 liters per day. As a result, patient has lower risk of experiencing nephrotoxicity, and if it happens, it can be managed as early as possible with frequent monitoring.
The last issue is the newly started efavirenz, which may give rise to central nervous system side effects. Pharmacists should inform patient to report symptoms such as vivid or abnormal dreams, feeling off balance, feels like falling over, feels like the room is spinning, unsteady walk, feels like body is spinning, feels lightheaded or feels hangover. The side effects usually improve with time and rarely persist beyond 2 to 4 weeks. If the symptoms are unbearable, patient should return to consult doctor. If it is decided not to restart antiretrovirals, efavirenz can be stopped while slowly tail off the 2 NRTIs, which in this case, is 10
As a conclusion, various disease-related and patient factors need to be taken in account when choosing preferred first-line therapy for each patient. Compliance of more than 95% must be achieved by compliance aids and patient education. Our goal of HAART is maximum viral suppression with minimum side effects for the longest time possible.
You are welcome to refer to these references for more details. We have reached the end of this presentation and it is time to live our lives forward. Thank you for watching Lively Life Snippets. Comment below on what type of content you would like to see from my channel in future. If you like my videos, hit the like and share button. Don't forget to subscribe and see you all in the next episode.